Thank you so much. And I have to say that I owe the Lupus Foundation of America a debt of gratitude. The LFA has funded 4 students in my lab over 20 years with a Gina Fincy Fellowship Award. And the work that I'm going to tell you about today would certainly not have been possible without the Michael John Barlin Foundation Award. I will tell you a little bit about the work that I'm going to do, but I'm going to start by reiterating some of what has been said already, that there is a huge unmet need. And I think Michael John's story is unfortunately rather representative of what we see in pediatric lupus. So I'm going to start with about 10 minutes on just sort of reviewing the state of the art. Where are we right now with pediatric lupus, and why is the need so critical? And so I'm just going to go through 3 little areas. Why is the focus on pediatric lupus so critical? What's being done? And where is this all going? Now, this is largely my opinion. I can't necessarily predict the future. So I just want to make the point, if you look at the graph on the left, this is the number of publications on the subject of lupus shown in the more maroon-colored line, and the blue-colored line is the number of publications devoted to pediatric lupus. Now, if 15% of patients with lupus develop their lupus in childhood, it seems to me that roughly 15% of the publications should be on the subject of pediatric lupus, but you can see that that's clearly not the case. That while there have been enormous advances in our understanding of lupus generally, that the focus on pediatric lupus really has not kept pace with our overall enthusiasm for studying lupus. And you can really see that on the right-hand graph, where I've graphed the percent of publications focused on pediatric lupus. And you can see that, well, back in the 50s, it was almost nothing. We still have not really reached, I think, the critical threshold that develops that massive energy that's really going to move the ball forward. I think that pediatric lupus research is still highly fragmented. It hasn't coalesced in the same way that studies in adult lupus have. And there are a lot of reasons for that. You heard about NIH cutting funding, but I think that there's not the same tradition of research in pediatrics as there is in adult medicine. And so we're trying hard to catch up, but we definitely have a ways to go. So another reason to really focus very much on pediatric lupus is really what you've heard already. So Michael John had really, unfortunately, a very typical experience with pediatric lupus. I wish I could say otherwise. Children have a higher damage index than adults, so the SLIC index really measures damage as opposed to disease activity. You can see that it's more than twice as much in kids as it is in adults. This indicates that not only do they have more years of living with lupus, but the disease is actually more intensive and more damaging in lupus. You can see this with a number of other metrics. So there's a higher requirement for dialysis in kids. 20% of kids end up on dialysis versus 6%. Again, you heard that as part of Michael John's story. There's a higher need for renal transplants, 3 times more in kids than adults. And then uniquely for kids, the medications, which we all acknowledge are efficacious but toxic, lead to growth failure and delayed puberty in kids. Those are not things that you would ever see in adults. And then importantly, only half of people with pediatric onset lupus are able to hold down jobs in adulthood. So that's a much higher rate of disability. If you define disability as not holding a job, that's a much higher rate than in adult onset lupus, which is already a very serious disease and a disease that has a huge burden. But I just wanted to make the point that pediatric lupus definitely has a very profound impact on the affected child. Well, I promised to talk about what's being done. I don't want to be completely negative because there have been huge advances in our understanding of lupus. And I want to break it down into 3 areas because when I talk about the research that's going on in my lab, you'll hear me talk about it as 3 different phases. And so typically when there's an idea, it starts on a benchtop, on a lab bench. It's just someone pipetting and there's clear liquids going around, and It's really something that is just related on a binge. And then the next step is to sort of understand how relevant it is for people. And that may involve something like drawing blood from people and testing their cells in a test tube. But the idea is you move from the binge, then finally you get samples from people, and that's called translational science. And then ultimately our goal is to get to the point where we've got a drug or a new intervention that's going to change the lives of patients for the better. And that's pure clinical science. So when I get to my story, I'm going to talk about it in the same three categories. But just to let you know, there is good news here. I really don't want this to be negative, although clearly there are unmet needs. In basic science, people are trying very hard to understand what causes lupus. They're trying to look at it in mice. They're trying to look at it in people. And that's a very basic science approach. I've highlighted in red that people are not really at the point where they're trying to understand why the onset is earlier in some people compared to others. What is it that's unique about pediatric lupus etiology compared to adult lupus? We do know it's a spectrum. It's not that pediatric lupus is a different disease. It just seems to be on the more severe end of the spectrum. And we haven't really gotten our toe in the door for that specific question yet. In terms of translational science, there's been huge advances in understanding the genes, piloting novel treatments in an in vitro or on a benchtop setting or in mice. And then in clinical science, definitely there have been new management options that have come down the pike in the last 5 years. I think this is especially important for kids, again, because they not only have more years of therapy and more disease burden, but they accumulate burden from the medications as well at a greater rate than in adults. The medications are fairly toxic. We all acknowledge that. But because the kids are exposed to more of it, they tend to accrue damage from the medication. So we need to be very careful in the way that we apply adult medications to kids. We need to identify markers of outcomes, and there has been a lot of work on understanding outcomes. And then finally, in the clinical arena, it's important to ask patients about their experience. And I think this is now sort of a trendy subject in clinical science. It's embarrassing that it is just now trendy. But just to give you insight into why this is so important, there may be a medication that all of the laboratory studies, all of the medical treatments make it look like a very effective intervention. But when you ask the patients, it makes them tired, it makes them feel crummy. It's not a good answer if it makes the patients feel worse than they did beforehand. So lots of work being done. I just want to highlight that. And where do I think this is all going? Well, I do think the need is critical on all fronts, specifically for pediatric lupus. I think while great progress has been made, translating some of that information to the pediatric arena is absolutely critical. You may have heard that there's a large registry across the United States that's designed to capture patient-reported information, so we really have a better sense of how the patients feel. But I think I think if you're on this call, I think you're energized and already know that we need to do more, that there is a great need, and there's really lots of opportunity to make good progress in the field of pediatric lupus. So I'm going to try to gently transition from sort of where we think we're at right now to why that made sense for the study that I'm going to describe. We think that the earlier onset of lupus, meaning pediatric lupus, reflects a higher influence of genetic contributions. There's not great data to support that. I was just part of a large consortium that looked at genetic causes of autoimmune disease in a very big way. So looked at multiple sclerosis and lupus and IBD, looked at a very broad range of autoimmune diseases, and looked specifically in a pediatric group. And it was hard to extrapolate from that study, but it did look as though earlier onset disease had more of an impact of genetic contributions. But it turns out that that's quite a difficult subject to answer. We think that the fundamental disease is the same in kids and adults. It's not that the kids are getting something different. They're just getting a more severe form of it. And we think that the management of kids needs to minimize medication damage but maximize organ function. And of course, every patient deserves that sweet spot. We want to be there for every single patient. But I think it's a more delicate equation in kids because you're trying to balance some of the toxic side effects that are uniquely present in kids that you don't have to worry so much about in adults. Next slide. So just to give you a little bit of framework, we know that 37% of kids will have a major infection, meaning hospitalization, IV antibiotics. So why am I mentioning that? It's because that's largely due to the medications. The medications are immune suppressive, and so unfortunately one of the consequences is a risk of infection. So I think that really sort of puts a fine point on that particular medication risk. We know 75% of the kids will have kidney involvement. Not all of them end up with end-stage renal disease, but my study is focused on the kidney disease, and so I just want to highlight that, in fact, the majority of kids will have kidney involvement. 15% of pediatric lupus patients die by early adulthood, and no one knows that more than the Barlins. It's a very sad fact, and although that treatments have improved for lupus overall, that number has not budged very much over the past 10 years, meaning that we have not been able to effectively address the worst possible outcome in pediatric lupus. I've talked about medication side effects. I just want to give you some very specific examples here. Steroids are the most widely used treatment for lupus, be it pediatric lupus or adult lupus. Some of the consequences of using steroids that we worry about are cataracts, fractures, and something called avascular necrosis, where the hip bone just sort of degenerates and dissolves. It requires a hip replacement. It's that severe usually. Uniquely in kids as well, of course, we have to worry about growth. And really, prednisone and cyclophosphamide are going to affect growth and pubertal development. And so, again, we need to be very attentive to those facets in kids. So let me tell you my story and the study that I'm doing. Of course, I'm very proud of it, but I wanted to ground it in kind of the state of where we're at right now. So the story I'm going to call the HER2 story, which probably sounds like my best friend or something like that. HER2 is actually a molecule that I'll talk about. And this started in basic science. It moved to translational science. And thanks to this award, we're actually testing it clinically. So what did we do? We had an idea that we didn't really understand lupus nephritis as well as we thought. And that's a little bit arrogant to say, but in our lab, we decided to really go back to basics and rather try and work with the information that we had to really do what's called a discovery approach, meaning we just throw all assumptions away and just say, let the kidney tell us what's going on rather than us imposing our ideas. And I'll tell you just a couple sentences about that. Then we moved to translational science. We wanted to understand, could this discovery be useful clinically? And again, I'll just tell you a couple sentences about that. And now we're testing it clinically. And our goal is to develop, ultimately, a dipstick where we would know if a kidney is starting to flare so that we could institute treatment earlier rather than later. And the reason is that the more recurrences of kidney disease that you have in lupus, the more likely it is that you will end up in renal failure and require dialysis and a kidney transplant. And part of the problem is that while it doesn't seem like it should be that difficult, it's incredibly hard to tell when a kidney is flaring. And you heard the Barlins talk about the kidney biopsies that their son underwent. Right now, that's the only way to know for sure, but it's very invasive. So our idea was to develop something simple like a dipstick approach. So with your permission, I'm going to tell you our story. So our rationale was that kidney disease is what gets most kids into trouble. Nephritis is more common in kids than adults. You've heard me say this before. The treatment is effective but toxic. And here are the two things that really sort of set us on this path. We as clinicians know that it's very, very difficult to tell when we should start treatment for a flare that affects the kidneys. Those relapses are not easy to distinguish because once a kidney has been diseased, then the urine will always have signs of the disease. There will typically often be protein and cells there, and you can't tell whether it's left over from the previous flare or it's something new going on. So that was the task that we set for ourselves. And then as you've heard, biopsies are invasive, and at this point in time, there's not a great substitute. So that's our idea. We wanted to develop a better monitoring strategy that doesn't require surgery. I know that was a bold thing, but that was our goal. So as I said, we were a little bit arrogant, and we said, all right, let's just not pay attention to what we all think we understand about lupus nephritis. We're just going to throw that all away and use what's called a discovery approach. So what's different about a discovery approach is that there's no hypothesis. You just sort of say, all right, tissue, talk to me. I know it sounds a little crazy, but that's what we did. And so we looked specifically at these regulatory RNAs. And the reason we chose those was because they're very stable and because there's a lot of data suggesting that these regulatory RNAs kind of tune the gene expression. And gene expression is just code for how cells are going to behave. And so what we started with is we took kidney biopsy samples from patients that were already known to have lupus nephritis, and we compared those with kidney biopsies from kids that had other types of renal disease. And so I'm just going to say a few words about this without diving too much into the biology of microRNAs. MicroRNAs are these little regulatory RNAs. And for us, they were just a marker. I mean, they're fascinating in their own right, but at this point, I'm just going to focus on what they told us. So remember, this was a discovery approach. We just ground up some kidneys and asked what their microRNA patterns were and said, please tell us what's going on rather than us trying to guess. And so you'll see that I've divided this into two sections, growth and proliferation and cancer on the left, and inflammation and immunologic disease on the right. And so these are, what these patterns are actually an algorithm that looks at all the different 750 microRNAs that we measured and says the differences that we see in lupus patients, what patterns do they belong to? So inflammation and immunologic disease, that makes perfect sense, right? We know lupus nephritis is an inflammatory disease. The ones that were surprising and the ones that I'm going to focus on are growth and proliferation and cancer. And so this theme is going to come up in a couple of slides from now, so just hang on to that thought. So I'm going to focus on two microRNAs, and again, these don't have sexy names and they're kind of hard to latch onto because they don't really, they don't seem that friendly like Tom or Harry, but miR26A and miR30B are just the names that are given to two of these microRNAs. And I want you to just notice, if you look at the bottom of this graph, you'll see that there's lupus nephritis class 3, class 4, and class 5. Class 5 is sort of burnt out lupus nephritis, and class 3 and class 4 are what are called proliferative lupus nephritis. These are the types of nephritis that are very damaging that go on to renal failure typically. And they're called proliferative lupus nephritis because you can actually see under a microscope that the cells are dividing and they actually sort of clog up the filtration system of the kidney so that you end up with a non-functional kidney. Well, notice that these two microRNAs are much lower in lupus nephritis than they are in the normals, which is the group over on the left of each of the graphs. So we did see significant differences. I'm not showing on this graph, but we also compared it to kids who had post-strep glomerulonephritis and a type of kidney tumor. And these were, the reason we're focusing on these two, the 26A and 30B, is that they were uniquely disturbed in lupus nephritis. Now, I mentioned this story about proliferation and how when you look at lupus nephritis under a microscope, you see a proliferation so that the filtration system is actually sort of clogged up. And so when we see that under a microscope, we call it crescents. And so we wanted to compare kidney biopsies that had crescents versus those that did not. So on the left, you see a graph that compares the level of 26A in patients with lupus nephritis that didn't have crescents and those with lupus nephritis that did have crescents. And you can see the more proliferative picture is associated with even lower levels of 26A, and the same is true for 30B. So the more proliferation we see, the lower the levels of these two microRNAs. So we did know something, not we, my lab, but the universe in general, knew something about these two microRNAs. They'd been implicated in cancer, which again probably sounds a little out there to you. It did to us as well. These microRNAs were known to regulate cell growth and proliferation. And so I want you to go back about 3 slides ago when I said when we looked at all of the 750 microRNAs, the 2 patterns that were most significant for lupus nephritis were, in fact, proliferation and cancer. And so we think that these 2 microRNAs are actually really important in the proliferative component of lupus nephritis, the actual feature of lupus nephritis that sort of chokes off the filtration system. Well, one other thing was known about these 2 microRNAs. They were regulated by a growth factor called HER2. And HER2 is a very popular biomarker in cancer because it, again, marks cells with a high proliferative capacity. And so we said, well, could HER2 be a biomarker in lupus nephritis? So if you look at the kidneys on the left, those are normal kidneys stained for HER2. You don't really need any science background to know that there's a ton more HER2 in lupus nephritis than there is in the normal kidneys. This is actually pretty unprecedented. I've stained a lot of kidneys in my life, and I've looked for a lot of biomarkers. You never see a difference this dramatic. This is really quite exceptional. So we were very encouraged by this. Next slide. You'll just see another picture just to show you that we didn't pick like the world's worst kidney. Really, every kidney that we looked at from patients with lupus nephritis had this dramatic expression of HER2. So it's one thing to find it in biopsy, but remember our goal was to try and develop a biomarker that didn't require people to have renal biopsies. And so we said, well, maybe if there's that much HER2 in the kidney, maybe some of it is being shed into the urine. And so we looked at the urine of patients with lupus nephritis. Now, this was done in adults, not kids. Although the story started in kids, for us to get enough urine samples to do this, we needed to transition into adults. So you can see easily that patients with lupus nephritis have higher levels of HER2. So if you look at the left-hand bar graph, that's just comparing controls and patients with lupus nephritis. So absolutely we can find HER2 in the urine. If you compare in the middle bar graph, what I'm comparing is non-active lupus nephritis versus active lupus nephritis. So it seems to correlate with disease activity. That was very exciting to us. And then if you look at the last bar graph, you can see if we compare class 3 and class 4, the 2 proliferative types of lupus nephritis with that of class 5, which is more burned out, you can see, again, big differences. So it does seem like HER2 in the urine is tracking with disease activity. And then the bottom sort of dot plots that I'm showing you are just showing that we tried to correlate HER2 with various other biomarkers that have been proposed. And although the one on the right has a reasonably good correlation, and that's VCAM. VCAM is a marker of inflammation. We actually think we're capturing a different aspect with HER2. We think we're actually capturing the proliferation rather than the inflammation. So we also looked at a fair number of adults that had lupus but had not been diagnosed with lupus nephritis. And the reason we did this is sort of in preparation for the study that I'm going to tell you about that's being funded by the LFA. We wanted to understand what was sort of the spectrum. So we took a broad range of lupus patients that were not known to have nephritis, and these again are adults. And what we're going to do now is go forward in time and ask if any of these people at the very high end of the HER2 levels go on to develop lupus nephritis. But that we have to wait a little bit for. So I'm going to take a tiny detour here and go back to the bench. So I'm going to end with the story of what our study is and what we hope to gain from it. But I think it's worth just pointing out that we actually learned something. Remember, we went into this as a discovery approach. And I think it's important to just make the point that it did teach us something fundamental about what's going on in the kidney. I'm going to skip the actual science and just show you a model of what we think is going on. Believe me, I would love to speak for a whole other hour about the science that led to this particular diagram. But I'll just summarize it all by saying we know that type 1 interferon is important in the etiopathogenesis of lupus. It turns out that this HER2 molecule is actually induced by type 1 interferon. This is completely new information, was not known before. In fact, HER2 had only been published as a cancer biomarker. So we think that type 1 interferons induce the expression of HER2 on renal cells. The HER2 regulates the expression of these microRNAs that I've been telling you about, these little regulatory RNAs. These in turn regulate proliferation by changing the expression of cell cycle genes. And so in this situation, the final result is that you end up with proliferation, crescence, and renal damage. And we actually were able to validate almost everything in this figure except for that little dotted line with a question mark. We have not been able to ascertain how HER2 regulates these microRNAs, just that it does regulate these microRNAs. So I'm really proud of these data, but here's the punchline. Because HER2 has been studied in cancer, there's actually a HER2-targeted therapy called trastuzumab. And we wonder if trastuzumab could be a therapeutic to treat lupus nephritis, because it would in fact block this pathway and perhaps mitigate the proliferation, crescence, and damage. So that's all hypothetical, but I think it does at least open the door to consider that as a potential therapy. So I'm going to go back to the study now. So based on what I've just told you, we know that HER2 measures the proliferative aspect of lupus nephritis. And our goal in the study that I'm going to describe is that we can track HER2 serially because it's non-invasive. The idea is that we can track it over time, multiple times in each patient. It's very easy to measure. It's very stable. So you'll see we're getting samples shipped from all over the country. And although my lab is not so into this type of technology, theoretically it could be made into a dipstick assay so that you could actually have a point of service detection of HER2. So here's the study design, clearly funded by the Lupus Foundation of America, and it's a prospective collection of urine, meaning we're going to collect urine for 4 years on all these patients. We're collecting urine every 3 months. There are 4 sites involved, so Children's Hospital of Philadelphia, and Sandy Burnham is the site PI for that. Kathy O'Neill is the site PI in Indiana. Laura Schanberg is the site PI at Duke. And Emily Von Scheven is the site PI at UCSF. We will follow 100 patients for 4 years. That's a lot of urine. My lab is up to it. We're all psyched. And we anticipate, just based on the statistics, that we will see 50 flares during that 4-year period. So we'll have all of this urine that's been serially collected. There will be 50 flares approximately. And the idea is to test whether the proximal urine shows an increase in HER2 that predates the flare. And that would clearly demonstrate that prospective determination of HER2 or serial determination of HER2 could be used clinically to predict renal flares. And that would be huge. So you don't know that it's going to work until the study is done, but that's the idea behind this study. This is a funny picture from my lab. You'll notice we are all ladies, and the National Institutes of Health asked us to make a video showing us as lupus warriors. So this is my lab in our interpretation of being lupus warriors. Next slide. I do want to thank, in a much more formal way, all of the people that are involved. I mentioned the 4 sites, Duke, Indiana, CHOP, and UCSF. Of course, I want to thank the Lupus Foundation of America and the Barlins and Cara for building a registry that gave us some foundation for collecting the data. Much of the data that I showed you today was done by Patricia Costa-Reyes, a very, very talented pediatric rheumatologist in my lab. There were contributions from Kelly Maurer, Li Song, Li Huaxi, Yutak Wang, and Michelle Petrie, who I've had a long-standing collaboration with. But I definitely want to highlight Patricia's contribution because she started this study. And I think that completes my component, and I believe we will open it for questions now.
Wonderful. Thank you, Dr. Sullivan. That was very interesting, and we love the picture of you as warriors. So we do have a couple questions, and we will open up the phone lines for people as well. But right now, I wanted to ask you, the one is, how can I get my child or teenager involved in lupus clinical research?
So, of course, there's lots more research going on than just my lab and this study. I will say that that the CARA registry crosses almost all institutions that are that have a significant pediatric rheumatology presence. This study is really only going on at the 4 sites that I mentioned, but there are other studies that are going on that utilize the CARA registry, and then of course there are studies that are unique to just 1 or 2 sites. So there are lots of ways to get involved, and it's great to see that enthusiasm and great to see the motivation of patients. And to be honest, I actually think it spurs researchers along. I think when the patients are enthusiastic, I think it really sort of embarrasses us to, pull up our socks and get working and really try harder.
So the next question we have here is, how does lupus clinical research in children differ than lupus clinical research in adults?
I think it's quite different. I think, so I tried to highlight the differences in the disease, but you're asking a question about how does the approach to research differ. And I think that a lot of it is founded on FDA requirements. So, of course, all new drugs are tested in adults first, and then only secondarily trickle down to children. And I understand why that is. It's because children are a vulnerable population. You don't want to subject them to risk without good reason to think that they'll get benefit. But it does mean that there can be a lag between therapeutics that are approved before they finally have evidence for their use in children. And I think that's a significant concern, is that sort of gap in medication approval for kids. So I think that's a significant issue. I also think that the bar is a little bit higher for research in children, again, because they're a vulnerable population. I think adults are able to consent for themselves and able to assess the risks and benefits of participating in any research trial, whereas kids, it's the parents that are consenting for them often, depends on the age. And so the bar is actually set pretty high. There needs to be a very limited amount of risk involved when kids are involved in a research study, and that's pretty universally the case. There are institutional review boards, but typically the bar is set higher for children, for pregnant women, for any vulnerable population. And again, I see why it is that way. It makes sense, but it does represent something of a hurdle when you're trying to do research in pediatric diseases.
The last question we have here is, are other biomarkers being studied in pediatric lupus?
There are. There's a woman that has worked for quite some time on biomarkers for lupus nephritis named Hermine Brunner, and she has identified, so you may have noticed that we compared her with 2 different recognized biomarkers. And in addition, she has a couple of others that she's been piloting. Her efforts have been predominantly directed at looking at markers of inflammation. And I think that she really did yeoman's work in trying to convince the planet that looking at biomarkers in the urine could, in fact, be predictive of lupus nephritis. So I think we all owe a debt of gratitude to her for sort of setting the stage. I do think that our work is a little different in that we're very focused on the proliferation component, which is it's the piece that gets the kidney into trouble. I think it's intimately related with inflammation, so I don't want to diminish the importance of that. But I think we're sort of capturing a different phenomenon when we look at HER2. And I think it's taught us something about the kidney, but I also think it's a great biomarker. You saw how highly expressed it was. I mean, this is super easy to pick up in the urine. It's very, very abundant as a protein, which makes it a great strategy for a dipstick approach because it's so prevalent in the urine. It's not difficult to detect at all.
When do you expect to have results from your urine studies? I know that the grant is a 5-year grant, and I think you said you were collecting it for 4 years.
We are. It's a very, very delayed gratification. It's just going to kill me, I think, to wait that long. So the idea is that we will collect for 4 years, and then data analysis will proceed in the 5th year. And so, we're certainly not going to be able to publish anything until that 5th year. Will we peak beforehand? Of course. Who could not? So we will absolutely be running some assays. And we are doing a little component. The adult piece, which is separately funded, is actually a little different in that we're going backwards in time instead of forward in time. We may get a little window into how useful this is by by looking at those adults, however. So there may just be a little glimmer of information that we get at the halfway point.
Great. Well, I say, Dr. Sullivan, thank you so much for being such an engaging presenter and helping kind of break down the science for us and really helping us, I think, all understand. And thank you to Wayne and Judy Barlin for all of their support and for sharing their story with us tonight. And I hope that you all have enjoyed the second installment of our research series focused on childhood lupus, particularly on lupus nephritis, and the research of Dr. Kathleen Sullivan. So with that, I wish you all a wonderful evening, and we look forward to speaking with you all again soon. Thank you.
Good night.